My name is Angelica Guidry. I am a psychology graduate student at Kaiser University in Florida. This presentation is based on an overview of suicide risk assessment and psychological assessments to address suicidal ideation. I will start by highlighting key factors about suicide, including definition and statistics. I will also address biological, psychological, and sociocultural risk factors linked to suicidal behavior. I have gathered and highlighted on this presentation several peer-reviewed journals to display the application and research of suicide risk assessments and psychological assessments addressing suicidal behavior, as well as other contributing factors that may increase the risk. If you are in crisis, the National Suicide Prevention Lifeline Organization has a toll-free number of 1-800-273-TALK. That is 1-800-273-8255. They are available 24 hours a day, 7 days a week. The service is available to anyone and all calls are confidential. According to the National Institute of Mental Health, suicide has been categorized as one of the most prominent causes of death in the United States. Furthermore, the exponential increase on death by suicide continues to be a national and international concern. Suicide is commonly defined as death by self-infliction. Suicide attempt is considered self-directed, injurious behavior with the intent to die as a result of the behavior. And suicidal ideation is a term used when referring to, thinking about, considering, or planning suicide. As it relates to suicide statistics, the Center for Disease Control and Prevention, as illustrated on the National Institute of Mental Health website, presented a report in 2017 highlighting the leading causes of death. Sadly, suicide was named as the 10th leading cause of death overall in the United States, claiming the lives of 47,000 people. Among individuals between the ages of 10 and 34, suicide was the second leading cause of death and named the fourth among those between the ages of 35 and 54. A staggering report shows that the count of suicide deaths is twice as many in the United States as there were homicides. The Center for Disease Control and Prevention also presented the percentages of the most common suicide deaths by method among men and women, including firearm as the #1 method, followed by poisoning and suffocation. There are several components that play an integral part as risk factors of suicidal behavior. Suicidal behavior is a very complex subject, and there are characteristics that tend to be present among those most at risk to commit or attempt suicide, including a series of biological, sociocultural, and psychological factors. Biological factors, for instance, may be directly linked to genetic contributors such as chronic pain, family history of substance abuse, family history of violence, and family history of suicide. Another biological factor is highlighted in the study, identifying those with low levels of neurotransmitter serotonin, which contributes to feelings of well-being and happiness, to be about 10 times more likely to attempt suicide than those with higher levels of serotonin. Social cultural factors also have a great influence on an individual's suicidal behavior, including attempt and ideation. The loss of a loved one, going through a divorce, as well as experiencing chronic economic hardship are all contributing issues associated with those that may have committed or attempted. Another social cultural factor is based on demographics around the world. According to the 2019 report of World Health Statistics by the World Health Organization, suicide is a global crisis that equally affects people from different social status, gender, religion, and culture. The top 5 countries with the highest risk of suicide per population of 100,000 are Lithuania, Russia, Guyana, South Korea, and Belarus, whereas the countries named on the report with the lowest risk of suicide per population of 100,000 include Afghanistan, Iraq, Syria, and highlighting the Caribbean islands of the Bahamas, Jamaica, Grenada, Barbados, and Antigua and Barbuda as having the lowest suicide rates in the world. Psychological factors will be featured in a larger scope on this presentation. There is a wide spectrum in which mental health is a major causative factor to suicidal behavior. An individual that experiences the effects of major depressive disorders, borderline personality disorder, post-traumatic stress disorder, including substance abuse, are at higher risk in engaging on the act to end their lives, make the attempt, or have recurring thoughts and triggers associated with suicidal behavior. These mental health conditions may also activate a feeling of hopelessness and emptiness for those already struggling with mental disorder and trauma, directly linked to suicidal acts. In recent years, there have been a vast and continuous effort to establish and improve resources for professional and clinical administration of suicide risk assessments to address the risk factors linked to the suicide and suicidal attempt and ideation. The main goal is to reduce the number of deaths associated with suicide, as well as preventative measures in which individuals with suicidal behavior feel empowered and equipped to address behavior and emotional cues that may lead to the urge of self-harm or self-inflicted death. According to a study on advances in suicide risk assessment, risk factors are outlined as essential in understanding some of the components linked to demographics and assessment of mental disorders. Nevertheless, risk factors are not necessarily effective as suicide predictors. The study further implicates that even if there is a clear indicator of a mental disorder, the correlation of suicide is not always linear. The researchers' notion is explained as even if the suicide risk in the United States is 30 times higher for patients diagnosed with major depressive disorder, risk only increased 13.4 to 402 per 100,000 in population, which is a mere 0.00402%, or 1 in every 247 patients with MDD dies by suicide. Psychologists and professional administrators of suicide risk assessments have a dire obligation to effectively assess the needs of the individuals in the order to reduce the risk. There are key elements to consider, including the following 6, in which authors Sommer, Flanagan, and Shaw argue that psychologists should shift the way in which they view, administer, and interpret the suicide assessments. Furthermore, pointing out that there is more critical to view suicidality as a trigger of distress as opposed to a form of defiance. Also highlighting the importance of displaying empathy and deep understanding of the patient's sense of pain, social connectedness, hope, and hopelessness. Here are the recommendations of the study for the clinicians to shift the paradigm of suicidal treatment. Acknowledgement that suicide risk factors may not play a big role in the application of the assessment by the psychologist practitioners. Encourage to move away from medical models and gear towards social constructions and collaborative orientations. Increase theoretical knowledge of suicidal behavior and observation of suicidal individuals. Recognizing that the clinical encounter and comprehensive suicide risk assessments are essential to developing and maintaining a therapeutic relationship. Embrace the advancements in how clinicians engage in questioning and interviewing the patient about suicide ideation, and clearly understanding the effective methods for monitoring suicide ideation over time. To effectively improve the interaction between patient and clinician, the emphasis on suicide risk should be minimized and not regarded as a mere focus of the consultation. Researchers explain that the mode of communication should shift to a mere social and constructionist one to create a comfortable and natural flow of communication and help build rapport and trust, eliminating the patient's feelings of being judged and opening to a collaborative problem-solving approach. Several suicide risk assessments, which have been studied and empirically supported by the American Psychological Association, are viable tools to address suicide risk factors. Following are examples including the interviewing process, personal suicide stigma questionnaire, the Minnesota Multifaceted Personality Inventory 2 Restructured, and the Peer Suicidal Intent Scale. An essential aspect of suicide risk assessment falls within the effectiveness of the interviewing process. This is a trending topic on many of the peer-reviewed journals while examining valid ways to administer suicide risk assessment. The emphasis continuously shifts to creating an environment for the patients that instills trust, comfort, and minimizes any rigid interview protocols that tend to exist in many traditional therapy settings. Researchers highlight 7 key mechanisms that make up what they refer to as state-of-the-art suicide assessment interview. They are as follows. Exploration and analysis of pertinent risk and protective factors with an emphasis on empathizing with and evaluating psychological pain, social connection, and hope or hopelessness. Using clinical strategies to ask directly about current and past suicide ideation. Evaluating as needed the nature of current and past suicide plans, including previous attempts. Assessment of patient self-control and agitation. Habituation to fear and or death. Assessment of suicide intent and reasons for living. Implementation as needed of a collaborative safety plan and alternative suicide intervention strategy that assists patients with concrete problem solving and addresses unique patient issues, including lethal means restrictions. Conducting a well-designed suicide assessment interview by applying collaborative factors between the clinician and the patient provide a clear approach to addressing the individual's therapeutic needs and ongoing measures to assess, monitor, reduce, and prevent suicide risks from the onset of the process. A detrimental factor associated with the suicide is based on the overall stigma surrounding that they have been attempted suicide and have experienced suicidal ideation. A study to address the stigma among those with lifetime suicidality designed the Personal Suicide Stigma Questionnaire, which was administered to 224 adult participants with the mean age of 32.68 years who had reportedly lifetime suicidality. The assessment was based on a 37-item questionnaire with a 5-point Likert scale of never, seldom, sometimes, often, very often. Furthermore, the construct of the assessment derives from other empirically supported scales such as the Self-Stigma on Mental Illness Scale, short form, and the Suicide Behaviors Questionnaire revised. Following are 4 examples of the items within the questionnaire. I have been treated as less competent by others when they learn about my suicidal thoughts or behavior. I have been shunned or avoided when others found out about my suicidal thoughts or behavior. Some people think that because of my suicidal thoughts or behavior, I will never be normal again. People think that because I have thoughts about suicide or engage in suicidal behavior before, I will do so in the future. The final model was based on 16 items of the 37 items as the most significant themes to address on the Personal Suicide Stigma Questionnaire. Although the design was credited as valid and suitable for a broad use, it does not effectively address psychopathology and psychological distress levels related to stigma. The Minnesota Multiphasic Personality Inventory 2 Restructured has been applied in different studies with a series of subscales to evaluate its utility in the prediction of future suicidal behavior, including veterans suffering from PTSD and encountering suicidal ideation, as well as other individuals who experience trauma in their childhood and struggle with suicidality as adults. Children now experiencing depressive symptoms and post-traumatic stress disorder due to maltreatment as a child were exposed to a 28-item self-report questionnaire named Childhood Trauma Questionnaire. The objective of assessment administration was based on assessing emotional abuse from childhood while formulating prevention efforts aimed at reducing suicide risk. Another study based on the MMPI-2-RF is comprised of a total of 1,100 participants within a forensic inpatient psychiatric facility, including 807 males and 303 females. The MMPI-2-RF is comprised of a 338-item self-report measure of personality and psychopathology, including 51 scales, 9 measure protocol validity, and 42 assess substantiated construct across the 5 domains, including emotion, thought, behavioral, somatic, cognitive, and interpersonal. The study concluded that the self-report data significantly substantiates that integrating psychological testing into suicide risk assessment is beneficial in addressing prediction of suicide risk. The Pearce Suicidal Intent Scale and the Beck Suicide Intent Scale are scales which are commonly applied to measure suicidal intent and classify suicidal attempters. The Pearce Suicidal Intent Scale was measured in utility in a study comprised of 469 participants described as suicide attempters. The study focused on the level of suicidal intent, which translates to understanding the intensity of the death wish, with a model of suicidal process from the lowest, which is wariness of life, suicidal ideation, to the highest, which is serious suicide attempt and completed suicide. The participants were both male and females, with a mean of 32.6 years and 33.2 years, respectively. The PSIS variables were based on 4 factors that were at a 62.1% of the total variances, including a wish to die, arrangements, circumstances, and alcohol and drug abuse. The study concluded that the level of intent to commit suicide is not gender dependent, increases with age, and both genders have a similar outcome related to individuals' components of suicidal intent. The fight to minimize the staggering increase in suicide and suicide attempts is an ongoing concern that triggers different aspects of life. An individual may silently struggle with suicidality and have a feeling of hopelessness, despair, and lack of support. The stigma associated with suicidal behavior also plays a vital role when individuals refuse to seek help. When other psychological factors such as mental health disorders and substance abuse are present, it sadly creates another element that may contribute to increased suicidal ideation. Suicide risk assessments and other psychological tests present a plethora of alternatives to design, administer, interpret, and continue to improve the models that have proven effective as well as ineffective in addressing suicidal behavior. Nevertheless, increasing preparedness in combination to empathy and sense of comfort are all common factors that were consistently addressed in the majority of the peer-reviewed journals, textbooks, and websites such as the World Health Organization and National Institute for Mental Health. Lastly, it is highly recommended that those struggling with suicide attempts and suicide ideation find even one person whom they can confide in and provide support. Seeking professional help at any scale is the first step in alleviating the struggles surrounding suicidal behavior, with the goal to find ways to cope and alleviate the triggers that lead to the drive to engage in self-harming behavior. Following are recommended guidelines as to what to do and what not to do when someone is threatening with suicide. What to do. Ask direct questions in a calm manner. Are you thinking about hurting yourself? Be a good listener and be supportive. Take the suicide threat very seriously. Encourage the person to seek professional help. What not to do. Don't ignore the warning signs. Don't refuse to talk about suicide if the person wants to talk about it. Don't react with horror, disapproval, or repulsion. Don't offer false reassurance or make judgment. Don't abandon the person after the crisis seems to have passed or after professional counseling has begun. If you are in crisis, call the toll-free National Suicide Prevention Line at 1-800-273-TALK. That's 1-800-273-8255. They are available 24 hours a day, 7 days a week. The service is available to anyone and all calls are confidential. Thank you for your time during this presentation.